and welcome to Deuk Spine Institute. We are streaming spine surgery live every week. This patient we're about to do surgery on comes from Tennessee. Kentucky, I apologize. Just making sure my staff are paying attention. And he has a very messed up back. Sorry for the lack of scientific terminology, but he's got a lot going on. Degenerative disc disease, herniation, annular tear, spondylosis, spondylolisthesis, pars defect, facet arthropathy, arthritis, hypertrophy, stenosis. I mean, the list keeps going. But we're not here to make his spine look normal. We're here to get him out of pain, and back pain is his primary problem. We're not fixing his listhesis because the bones have basically ground themselves together. We're going to fix the two discs above, L3-4, L4-5. Just to verify, guys, right L3-4, L4-5, and then left 4-5, correct? All right. How's he doing, Dr. B?
Very well.
All right, I'm going to get started then. Shot. Okay, I could probably be a little lower. And we'll get started here. Num. So the first step in fixing somebody's damaged disc that's causing back pain and pinching their nerves is really getting into the disc itself. And the way I do that is I use a needle. It's called a spinal needle. And our patient is sleeping right now. He's lightly sleeping, so he can actually help me. All right, that's the L4-5 right there. Shot. And you can see the L5-S1 has a slippage as well. The one below, shot. So 4-5 has a slippage, 5-1 has a slippage. Shot. The 5-1 slippage I think is stable. Shot. That's why I'm not doing anything about it. Shot. 4-5 I think is painful. Shot. Perfect. I can feel the herniation there. There's our one drop of blood. All right, we're going to access 3-4 next. We've already accessed 4-5. We're going to get into the 3-4 next. Now, that these disc problems can be so painful. What causes that pain? What's the mechanism?
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
All right, you can see from our video that the pain people experience when they have a herniated or degenerated disc, it actually comes from arthritis, inflammation. The inflammation is happening in a tear in the back of the disc. We call it a posterior annular tear. Shot. All right, look at that. Now, he's got bad scoliosis too because I'm actually lined up on both sides in the same place to start with, and yet I was not able to get to the same trajectory. Shot. All right, now I'm working on the next side, left. Shot. Thank you, Jordan, for caring about my little fingers. We use the X-ray machine to localize and to navigate. Shot. We're almost ready for him to be awake, Dr. B, if that's going to be an option, which would be nice. AP. So at this point, we have needles on the right side into the discs, specifically into the herniations and tears. And we're going to be testing them in just a moment. Perfect. There's the scoliosis I was talking about. You see it?
Yes, we do.
So he has a lot going on. We're not here to fix scoliosis. We're here to fix his pain. And that we're going to do. And a lot of doctors tell you you need to get rid of scoliosis with fusion, but it's not true. You don't need that fusion done. We fix pain from scoliosis all the time without fusion. Shot? Let's get another AP. I think I'm right on the herniation. I think he can feel it too. He didn't like that. Shot? Yeah. That looks like we're right on the herniation. Is he reliable?
Doing fine. Yeah. How you doing, my friend? You okay? He said yes, he is.
Where do you feel this?
Where are you feeling that?
Shot?
What location? I'm sorry?
Shot?
He said lower. Yeah, lower left side.
All right. Shot? Where do you feel that? Shot?
Where are you feeling that? You having back pain, or where's that traveling down the
Where do you feel that?
He's not feeling much, he says.
Shot? Shot?
You got a good number.
AP? All right, we're just about ready to test him. Okay. 2 lateral. Like to be a little bit more medial. Shot? Very good. Are you comfy?
He said yes.
Now, how long have you had back pain for?
How many years? 40 to 50 years.
All right, 40. So this patient has had lower back pain for 50 years. We had one the other day for 55 years. You guys remember that?
Yes.
50 years. It's so sad to see somebody living in pain for that long. And he's had pain coming from different places. He has 6 places where he's having pain from today. 6 spots. I found them before surgery. 2 discs, and then 6 facet joints. And we're going to fix all 6 spots. Are you comfy? Any pain? How bad is that on a scale of 1 to 10?
Give us a number.
How high?
What number? 8.
Is that where you get pain?
Yes.
Concordant, 3-4. All right, is it better now?
Somewhat better.
All right. Should be easing up. Jordan, show us the tear at 3-4 where the pain comes from. That's where the pain is coming from, a tear in the back of the annulus. Better?
Yeah.
How bad is that on a scale of 1 to 10? 10. Is that where you get your pain? All right, so 4-5 is a 10 out of 10. Concordant. 3-4 was an 8 out of 10. When you wake up, that pain will be gone, my friend. Gone for good. And it won't come back. So we know where his back pain's coming from. It's coming from 2 discs and 6 facet joints. We suspected the facet joints when I saw him on Zoom, but I had not confirmed it until today. Shot. All right. First disc to be repaired will be L4-5. Remember, 5-1 is just way too collapsed, and it's actually auto-fused. Shot. Hold on. Go ahead.
Can I?
Yeah. Mm-hmm. All right. Okay, that's very strange. We're going to have to redo that level. We need a needle back, and I'll need to reposition that. Let me have a roll, blue towel. All right. Let's, what was that, 4-5? Let's go 3-4. Guide wire. Our guide wire got kinked up pretty bad. Shot. All right, at this point, we're going to have to come back and reposition that needle. Fucker. Shot. All right, so we're going to start with 3-4. We were going to start with 4-5, but we had to remove the guide wire because it bent around the tip of the needle of the dilator. Take it out. First time for everything. Henry, let's show the audience how the Deuk laser disc repair works. This is endoscopic surgery, laser assisted.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, and while you were gone, we've been diligently working at this 3-4 disc to clean it up. Where is the glass fiber, Luis?
Okay. Vice grip, please. Vice grip. I mean, not vice grip, slipper, please. Open it, please. 1,000. Bigger. 1,000. Yeah.
These are all pieces of herniation we're taking out.
We have a couple questions.
Sure, we'll take them.
This first one coming from Dean on YouTube.
Dean.
Dean.
Welcome, Dean.
Saying, this describes me. All of what the doc said is what I have since 1991 of August. Multiple surgeries. Can arthritis be helped with this procedure?
Yes, Dean, this is the surgery you need right here. You're watching it. Back pain comes from damaged discs. This is a damaged disc. Just as you saw on the video that Henry showed you a little while ago, the damaged disc causes back pain through a process of inflammation. It is the inflammation that causes the back pain. Your body feels inflammation. Your body doesn't like inflammation. Inflammation hurts. When you have inflammation in your disc, it's like having a pimple in your disc. And every time you get up and move, you're putting pressure on the pimple. Imagine a really bad pimple. You stick your finger on it and just shove your finger into it. It hurts. It's tender. Imagine that tiny little pimple. This herniation is about 10 times the size of a pimple. So the tear and herniation together are a pimple in your disc. This is where pain comes from. The reason you haven't heard about it before is because I discovered it. I is in the guy operating right now, Dr. Deuk Majan. I am the one who pioneered it, discovered it, pioneered this treatment for it. And people come from all over the world to get this done because it's the only thing that works to get rid of the back pain. So yes, we cannot get rid of arthritis or cure arthritis, but we can get rid of the symptoms of arthritis, which is the pain. Your disc will never look normal again. We don't do this surgery to make this look normal. We do this surgery to get rid of back pain. All right, this is all scar tissue from chronic inflammation. 50 years of inflammation tends to make a lot of scar tissue. Scar tissue comes from inflammation. If you don't have inflammation in your body, you can't make scar tissue. Scar tissue requires inflammation. No inflammation, no scar tissue. It's a direct relationship. The more inflammation you get, the more scar tissue you make. So this is all scar tissue in your disc as the body is trying to heal the disc. See, that tear in the back of the disc or the wall of the disc, the annular tear, it's cool, man. Doesn't cause any problems. And then you get a herniation into the tear, and then that herniation causes inflammation. And that's where all the pain and suffering comes. All right, there's the tear right there. You see the tear? Right there, guys.
Yes, we do.
See it? It's like hard to miss. It's pretty obvious. And the blue coloration is the Deuk spine dye that we use to stain the herniation inside the tear, so I could see the tear. All right, keep the questions coming.
Next question coming from the classic car nut on YouTube.
By the way, the reason we did not broadcast the last surgery, the patient didn't want to be broadcasted. So not all of our patients want their surgeries broadcasted, and when they say no, we have to comply. So that's why we had a long break. All right, the classic car.
Classic car nut on YouTube.
Yes, Dr. B, everything all right? Go ahead, Henry.
Asking, hi, how close do you get to the nerve roots? I have zero back pain, just bilateral lower leg tightness, pain that follows at the L4-5 pattern. Would the DLDR help my issue?
Yes, the DLDR is your best option if your pain or discomfort is coming from pinched nerves. That's the first thing I would have to confirm, because it may not be. It may be coming from something else. Could be the piriformis syndrome. Could be a hamstring that's torn and tight. Could be ischial tuberosity tendonitis. You know, the first thing we need to do is diagnose the cause. If the cause is indeed nerve root related from a herniation pinching the nerve root, or scar tissue and a herniation pinching the nerve root, then this is your best option. There's no better surgery in the world. The other option would be a multi-level decompression, laminectomy, and fusion with screws, rods, and cages. And I wouldn't recommend that unless I did it for you, but even then, why go through that procedure? Far more invasive and dangerous. This is the best you can do right here. That's why we do this surgery over and over again. Because it works every time. For disc-related issues. All right, great question so far. Remember, we are currently on the L3-4 right side, and we had to pull out the L4-5 because our guide wire and our dilator got it stuck together and basically crimped the guide wire. So now I have to redo that needle and guide wire with the x-ray machine. Next question.
Next question from Izod on YouTube.
Sure, Izod on YouTube.
asking, I have cervical stenosis and a knee injury, meniscus tear, and ACL tear. Now I have developed imbalance in my gait. What should it be associated with, and which surgery should be done in priority? And the right knee injury was due to a road traffic accident.
Yeah, it's a great question, and I appreciate you asking me. Basically, if your cervical disc disease is pinching your spinal cord, causing balance problems because your spinal cord is being crushed, then that is your priority. Anytime the spinal cord is involved, it's always the priority. Okay? If the disc injury in your neck is not pushing on your spinal cord or damaging your spinal cord, then you can wait on the disc injury in the neck, though I would tend to want to fix that first, especially if it's symptomatic. I would strongly recommend you do a free MRI review with me. Let me talk to you and examine you and evaluate you and help you make a determination. The MRI review is just that, it's free. There's no obligation to treat, it's just free advice. It takes 10 minutes to do for us. You do have to fill out the paperwork a little bit, but it's worth it. You get to meet with me face to face, one-on-one. I get to figure out what's wrong with you and tell you what it is, and I give you my recommended treatment. You can even ask me a few questions, time permitting. So that's what I would do. All right, you can see the end plate, which is the bone to the right at about 3 o'clock. It's smooth, it's pink. I'm working on this tear and a lot of scar tissue right there, like a giant chunk. So much scar tissue because, well, over time, all that inflammation has created a tremendous amount of scar tissue in the disc. Specifically the herniation and the annulus. Very inflamed. You could see, if you rewind a little bit, right when I got to this part of the disc, there was some pink material at the 12 o'clock position, which is now 9 o'clock position. And that pink material is the inflammation happening. That's what we're here for. This is all scar tissue at the 12 o'clock position. You see that? Scar tissue. Now in that scar tissue is herniation. Thanks. I want to get rid of really the herniation primarily. Damn it. A little bit of epidural vein bleeding, very common in spine surgery. Comes from what's called Batson's plexus, which is a bunch of veins that live around the nerves. The nerve root that somebody was asking me, how close are we to the nerve root? The nerve root that we're operating next to is just right there, behind that metal shield. Might be able to show it to you. It's going to be the L3 nerve root in the foramen, the exiting root. For those anatomy buffs out there. And this is the last part of the disc, the most outer part. Any more questions, Henry?
Yes, we have a question from TDTM on YouTube.
TDTM, welcome.
Asking, do most spinal misalignments result in a halo brace? How severe is enough on top of multiple areas to be looked at?
Well, first of all, a halo brace is only for people with complex cervical spine fractures. I'm not sure why the doctor puts you in a halo, but a lot of times we'll put patients in a halo if we're trying to get their fracture to heal with conservative treatment. And The most common fracture we treat with a halo is a C1, C2 type fracture, usually an odontoid fracture of C2. So it's trauma-related fractures in acute phase, usually within the first 6 weeks to 3 months of injury. So if you're in a halo for another reason, I'd be interested to know why. You could also be put in a halo if you're considered to be highly unstable by your surgeon. Let's say you have a tumor or infection destroying your spine. The surgeon may want to put you in a halo just to treat the infection or tumor. All right. Not too bad. We're making good progress. Just about done. Grab her. Remember, we gotta re-stick the L4-5. Any more questions?
At this moment, no current questions.
Lots of little chunks. There's the outside of the disc right there. You can see the tear goes all the way through to the end. Bad tear. We saw this thing on the discogram, remember?
We have a question
Sure.
coming from Mixin on Up on YouTube, asking, when doing a cervical procedure, are you going through the annulus and disc to get back of the disc, assuming you go through the front?
That is correct. You are correct. We go through the front. We go through the front annulus. We go through the disc to get to the back. That's exactly what is done. Good job. Man, this is a giant thick wad of scar tissue right there. Like a big grape of scar tissue. Partially calcified. But this is his body trying to heal this injury unsuccessfully for 50 years. 50 years he's had this problem. If only he had met us 50 years ago, right? Could have had 50 more good years of life. All right, feel free to ask questions. Just about done. I'm going to be done in a minute, and then I'm going to reposition that needle that we talked about earlier. So just cleaning this stuff up really helps get rid of the pain. It's quite impressive. Our pain relief rate is 99.6% on average. That's an average amount of back pain relief from the disc when we do the repair. So, of course, you have to have discogenic pain. Disco is disc, genesis means to create or originate. Discogenic pain is back pain originating from the disc. If your pain's coming from something other than your disc, this surgery doesn't work, right? All right, so let's take a look, see if we can see the nerve. The nerve is going to be in that fat right there. We can't see it because it's in the fat. Oh, a little bit of disc there. I'm going to go back with the laser for a second. You guys see it?
Yes, we do.
Just under the nerve root. It's calcified. You see that calcium there, that white stuff? All right. So far, really good. We're done with this disc. I'm going to go back and work on 4-5 next. Feel free to ask questions.
We have another question
Sure.
coming from Mixing It Up on YouTube once more, asking, is this procedure any different when patients present with severe radiculopathy make sure the nerve root is free and happy?
No, this is the same procedure we do for radiculopathy. It's the same. Yeah, because we're not only able to treat the back pain, but we're able to unpinch the nerve. This is the perfect way to unpinch the nerve. The nerves get pinched in the foramen and lateral recess. That's where they get pinched. And traditional spine surgery exposes the central and paracentral region, but this is the foramen and lateral recess of exposure, and it's the best. So 98% of nerves are pinched in the neuroforamen and lateral recess. This procedure goes directly through the foramen to the lateral recess. It is the most direct approach to get to where the nerves are pinched. Laminectomy and microdiscectomy are horrible, because they don't get you to 4-5, correct? They don't get you to the lateral recess and neuroforamen. Microdiscectomy gets you to central and paracentral, and that's not where the problem is. Never is central and paracentral. Shot? 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 AP? So I'm having to redo the needle at 4-5 because the guide wire got mixed up with the dilator tip and just total mess. It looks good. Lateral. Any questions?
Yes, we have another question from the classic car nut once more on YouTube.
Sure.
Asking, if someone waits a very long time to have this treatment, is it possible that they may
Shot.
have permanent nerve damage?
Yeah, waiting too long will give you permanent nerve damage. That's right. So the sooner the better to get fixed. I always tell people, don't mess with your nerves. Shot? You know? If you want to change your hair color to, from blonde to brown or brown to red, and you wait because you're not sure, good, no problem, wait. But when it comes to shot, herniation, don't wait. Shot, take. Yeah. Like I said, I wish I could have gotten to this patient years ago to fix him. I think he's going to do really well once we're done. And he's recovered. Good. Keep the questions coming. So don't delay when you have nerve damage. Get it fixed sooner than later. Some doctors tell you wait till you're in a wheelchair. I disagree. If you're in a wheelchair, you're probably going to stay in a wheelchair. Why do they say that? Because they're afraid. They're afraid to have a complication. And they'd rather you start in a wheelchair than they put you in a wheelchair, because then you can't blame it on them. Listen, I'm just as afraid as other doctors. I'm a good surgeon, but anyone can have a complication. And doesn't matter how good you are, if you have a complication, you run the risk of, obviously the patient has a problem they're going to have to live with. You run the risk of being sued. So a lot of doctors are so afraid of lawsuits that they make the patients wait till they're already paralyzed and then they operate. I don't think that's right to do that to somebody. That's condemning them to a life of being in a wheelchair when you can fix them much sooner. So I'm an aggressive surgeon in the sense that I aggressively attack diseases that harm people and destroy their quality of life. But at the same time, I put myself at risk for being sued. God forbid something bad happens, because I aggressively pursue treatment for the patient, with the patient. Okay? It's just a difference of philosophy. And you're going to have surgeons who believe they should wait till the patient's, handicapped before they operate. And you're going to have surgeons who believe we should prevent the patient from being handicapped and operate early. I'm an early operator because I've seen the results of early intervention, and I know they can be very, very favorable. They can really keep people from having a lifelong handicap if you get to their back soon enough or their neck soon enough. You can prevent it. All right, we're working on disc number 2 out of 3, Berndes. We've got probably another 8 minutes on this one and then 10 on the other. Then we have our DPR to do. And I don't know if I told you guys, but there are 30 causes of back pain, 30 common causes of back pain. But they're not all equal, okay? Some of them are more common than others. And the most common cause of back pain, by far, 86% of chronic back pain comes from this, the disc injury. So if you've got back pain, or you know somebody who's had back pain for years, it's 85% chance it's the disc is the primary source. And it's specifically this exact thing we're working on. It's called the annular tear. It's in the back of the disc, not the front, not the sides, literally a posterior annular tear. And we've published this data in our Deuk laser disc repair paper. And I've talked about it thousands of times online. But the 86% of chronic back pain coming from a disc injury, that's new data that we got from reviewing 500 of our patients and seeing where did their pain come from, how did they respond to the treatments. And the patients that had disc pain, like this gentleman that ended up having the Deuk laser disc repair, we got rid of 99.6%. That's virtually 100% of their pain. Okay, 99.6. You round it up, it's 100. 99.6 rounds up to 100. So we really statistically got rid of 100% of discogenic back pain, and that's patient-reported outcomes, meaning our patients told us. We asked them, how much of your preoperative pain did we get rid of in this area? And the average answer was 99.6. We had a lot of 100%. We had a few 90s and a few 95s, but the average was 99.6 out of 503 patients. Okay? So what does that tell you? Most common cause of back pain is the disc injury, injured disc. You guys have different names for it: herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, slip disc, bulging disc. It's all the same thing. It's all a herniation. Just different ways of calling it a herniation. I'd love to say the disc is more complicated than that, but the disc is pretty simple. It's a wall and it's jelly in the middle. It's like a donut, right? A wall with jelly in the middle. By the way, there it is right there. You guys see the pink? That is the inflammation happening right here in front of us in real time. Okay? That's where all the pain comes from. Zap that area. This is L4-5. This was the 10 out of 10 pain. When I asked him how painful this disc is, 10 out of 10. You can see why. Lots of inflammation, highly visible. That area, by the way, if you take the glass fiber, it's 1 millimeter wide. That fiber right there, the glass part, 1 millimeter. So remember, go back and rewind and look at that pink area, okay? That pink area is probably like 5 millimeters. It's tiny. MRIs can only see down to about 3 to 5 millimeters. So the resolution of an MRI is barely enough to see that area. And we call it a high intensity zone, HIZ. You see it as a white area within the back of the disc. That's where the inflammation is. And that's where the pain comes from. We discovered that at Deuk Spine. We're the first to discover it. We're the first to treat it in the world. And unfortunately, I've told thousands of doctors about it, but they still want to do fusions because that's how they make their money. Not good for the patient. All right, any other questions?
Yes, we have a lot of questions. This next one coming from the Classic Car Nut once more on YouTube, following up on his previous question. So is it safe to say that this patient you are working on right now will have permanent nerve damage?
No, it's not safe to say that this patient will have permanent nerve damage. We never said the patient had nerve damage, though he does. He has pinched nerves, and he has some weakness on his exam from the pinched nerves. I believe the patient could make a full recovery. It depends on who does the surgery and how they do the surgery, okay? You guys think, all right, you're a classic car nut, right? I assume you like classic cars. All classic cars are not the same. A Chevy and a Nova are not the same car, right? I mean, they're different cars. Ford, Chevrolet, there's different makes and models. Okay, they're not all the same. They're all cars, but they're not the same. Spine surgery is all spine surgery, but it's not the same. It all depends on, the make, the model. It depends on what surgery is being done and who's doing it. If I did a microdiscectomy, which I've done hundreds and hundreds of microdiscectomies in my career, it is different. My microdiscectomy is different than the next surgeon. And that surgeon's microdiscectomy is different than the next one. The only thing they really have in common is few elements. One is they make an incision in the back, perimedian. You peel the muscle off the spine. There's a lot of bleeding and muscle trauma. And then how much lamina you take, how much facet you take, how much ligament you take varies. But what they all have in common is they all take lamina, they all take ligament, they all take facet. Okay, when I say take, it means remove, which is bad for you, the patient, by the way. You don't want to have your lamina removed, you don't want your facet removed, you don't want your ligaments taken out. You need those things. But to get down to the disc from the back in a microdiscectomy, you have to do that. Otherwise, you're not going to make it to the disc. Okay? But the technique I use here is different. I don't go through the lamina facet. I come around the side of the facet. So we go through a natural opening. And this technique was discovered by a very smart surgeon, Dr. Parvis Kambin. He was an Iranian surgeon, He worked in Philadelphia back in the 90s, and he thought about this technique called the Wiltse approach, named after a neurosurgeon who developed another way to get to the disc, basically a foraminal herniation, called the Wiltse approach. And he said, why don't we take an endoscope, and instead of doing an open Wiltse approach, we'll do an endoscopic Wiltse approach. So it started with Wiltse, then it went to an orthopedic surgeon, Parvis Kambin, and then it went to Dr. Tony Young and Dr. Reuten, and everybody changed the way it was done a little bit, making it a little bit better. And that's what we've done. We've taken the same type of surgery that's been done for ages, and, well, I shouldn't say ages. I mean, 100 years maybe. And we've improved upon it and made it better. Okay? And now we have truly the very best available in the year 2024. And that's what we do. All right. I know there's more questions and I'm talking too much. So.
Not a worry. This next question coming from Izod once more on YouTube.
Just not having any luck with these little pieces of herniation. They're just sitting around blocking my view. All right, Izod.
Izod asks, if there are no symptoms yet the MRI tells the graver story, will you advise the surgery or to wait for the symptoms to emerge?
You know, Izod, that's a really dang good question. I love it. So let's take a patient with a disc problem, and they're young. They have a lot of years ahead of them, and they have, let's say, no symptoms. And then I examine them. And let's take two scenarios. No symptoms, but when I examine them, I find weakness or numbness from a pinched nerve. I would definitely recommend surgery under those circumstances. So if the patient has no symptoms, but the physical exam findings are such that I find weakness, then I would recommend surgery. Now, scenario 2. Patient has no symptoms. They have no physical exam findings. And here's the key. They are living life to the fullest. There's no hesitation, no withholding activities because of pain and other symptoms. In that case, I would not recommend surgery. There's no symptoms. They're getting everything they want out of life. There's no reason to do surgery. Okay? Surgery is unnecessary at that point. All right, we are done here, and I'm going to move on to the next disc.
Why would a patient with no symptoms show up?
Well, a patient with no symptoms would not show up. He's just saying hypothetically. Let's say you're scanning and you get a kidney MRI and you happen to see a herniated disc, right, next to the kidney on the spine. Incidental finding. No symptoms. Patient has no symptoms whatsoever. And no exam findings. I would not recommend surgery. Nobody should. No doctor should recommend surgery. Oh, you're killing me, Luis. Fucking crap. All right. Great questions. Love the theoreticals.
We have a couple more questions.
I have a couple more answers.
This next question coming from the classic Car Nut once more on YouTube, asking what are the infection/complication rates with this surgery?
It's a great question. We've had 0 complications with this surgery. 0 surgical complications. Okay. We had 1 anesthesia complication a long time ago. No surgical complication. We've had no infection. We've actually used the surgery to treat infection of the disc, which is a very good use for the surgery. We had a patient who came, he went to Spine Institute in Virginia, had a microdiscectomy, got an infection, came to me. We went in endoscopically and cleaned out the infection. The infection went away. He did really well. So this is a great surgery to treat infection of the disc. Disc infection, okay? Because you don't have to open the patient up. Hold on. Let me just think. All right. You don't have to open the patient up. You can do it through this tiny incision. So they can do it outpatient. And I can put antibiotics in and leave them in the disc through this procedure. So we did that, you know. We left vancomycin in there. And the patient cleared their infection really nicely. Keep those questions coming, Hen. I'm going to back it up a little bit.
This question comes from Moises on YouTube,
Moises, been a while since we've heard from you.
asking, is the wood map in the waiting area with charms on it indicate where people have come from? And if so, Can you put one for me from Annenberg, Texas?
Of course.
Not a problem.
Yeah, hold that. Yeah. Yeah, the wooden map in the waiting room is supposed to be where people come from around the world. And Dr. Davis will personally make sure we get your location from Texas. You know, but the truth is that sometimes we don't get everybody on there because, well, we get busy and we're human and we make mistakes and we don't actually get all of our patients on there. So I'd say it's a pretty good representation of where our patients are from. Great question. Great to hear from you.
And at this moment, no current questions.
All right, the reason the view is not so good is we have a little bit of red blood cells or blood in the water, in the irrigation. Grab her. And the reason we do is, remember, this same disc we operated on the other side, right? So I've got blood passing actually through the disc itself from one side to the other. There's not much bleeding with these surgeries, but whatever bleeding you see is, remember, magnified 100 times. You can't do surgery without some blood. There's the tear. You guys saw the tear, right?
Yes, we did.
Everything okay? Any other questions?
At this moment, no current questions.
Let's go ahead and do we have any other videos we can show? Why don't we show the 30 causes of back pain,
Not a problem.
since we talked about it. I'm Dr. R. Deuk Majin with the Deuk Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Deuk Spine or Deuk Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deuk Majan. Thanks for joining us. All right, you can see from our video we have nicely outlined for you all to see these 30 causes of back pain. Of course, some of them are under the other category, which is not something we talk about very much because they're so rare. Other represents less than 1% of the causes. So 99% of back pain is facet, disc, SI, and piriformis. Fractures, coccyx, infections, tumors, very rare. All right, any other questions?
Yes, we have a question from the Classic Car Nut once more on YouTube.
Uh-huh.
Saying, thanks, Doc, by the way, and respect for what you do.
Thank you.
If it's determined that my radicular issue is caused by a disc issue, would you first advise patient to get a epidural to verify location of the symptoms?
No, you don't need an epidural. You need just a teleconsult with me, and I'll tell you where your symptoms are coming from. The epidural is just a money maker for the doctor. That's all. I don't recommend epidurals anymore. Very rarely do I recommend an epidural. We offer them because they're standard of care. You can offer an epidural. But the truth is, if you have a problem with a disc and a nerve, get it fixed properly. Epidural is not fixing it. The epidural can buy you some time. If, say, you're going on vacation, you don't want to have surgery, or you're a teacher, you want to teach for a few more months, then you're taking your break. You're going to have surgery when you're on break. That's fine. Then do the epidural, But epidurals don't fix anything. They only make you feel better for a little while. And some people don't get any benefit at all from the epidural. And there's a video we have on epidural. You can see that there are people that have had complications from the epidural. So my feeling is hold it. Why have a procedure that doesn't fix you, that has a pretty good risk of complication. Dr. B, we're just about done. Taking the last bits of herniation. He really shattered this disc. This disc is in bad shape. It's been damaged severely, but yeah, the good news is once I'm done here, it won't be painful and it'll heal. It will never heal normal. Remember, our goal is not to, we're not here to do plastic surgery of the spine to make your spine look normal on an MRI. Our goal is to get rid of symptoms. And we can do that without making your spine look pretty.
Two on, please. Thank you.
All right, we're gonna wrap this surgery up. We're gonna stream again with the Deuk plasma rhizotomy, which is next. We're going to be killing the pain nerves to his facet joints because he has facet pain. If you watch that video we just showed you, you'll see that facets are the second most common cause of chronic back pain. Not everybody has facet pain, but some people do. And when they do, you got to treat those facets or the patients will still have back pain after your surgery on the disc. Discs and facets are totally separate. Come on in, Jordan. Scope use is an 8. All right, so I'm still putting a little pressure on the incision and the muscles because he's oozing a little bit from his veins. And Luis and I are stapling the other side. Alrighty then, so we're going to be treating the facets. I'd go, let's see, that's got to be 3, 4, 5. So those are the 3 we're doing right there. That's perfect. Hold on a second. Let me have a stapler. Wait, let's get that up. Pickup, where's the pickup? Thought you were handing me the pickup.